Next speaker is Dr. Ivan Vukassinovic, and he's going to talk about workflow impact on clinical outcomes.
Thank you very much. I will present our experience for what we already talked about and Iris talked about and everybody else. So what is the major question for a stroke organization, of course, aside of training, is how to save time. And as Iris pointed out, in every 9 minutes we lose 1%, let's say, it's roughly say, of the good outcome. You know that the good outcome was for the 6 hours is around 40% in the randomized controlled trials. But you see, if the patient is recognized in the first 3 hours, then it goes to the 85%. Almost all the patients doing well. So if we could shorten the time, we could expand the number of patients, the percentage of patients doing well. And so how to save the time? For example, one of the questions is neurologists receive the patient or call from the remote hospital. It's a neurologist in our case, and he sends the pictures to us. And in fact, it calls us. It's not the case. We wait for all the pictures, all the CT, CTA, and everything to be done for us to come as we are on call. One of the things is, as also Iris said, they start all the drapes and everything before the pictures coming. We were doing at the beginning of our journey with the thrombectomies. We were coming before the pictures, or just seeing the middle meningeal hyperdense sign going there, and we were better in the results. So to have a discussion with the neurologist and the others and make a quick decision, we almost often it takes us 20 minutes, 15 minutes. Neurologists, they are a little bit, wider to discuss. We want to go and do it, but indications, contraindication studies, well, go on. It can take even 15, 20 minutes, which we lose. In case of a disagreement with the neurologist, we convince each other, but not fight. That's in the reality not true, because the neurologist is taking the final decision is by them, because they are afterwards treating the patients and they have the beds, as we say. We don't have a clinic. Another thing is direct admission to the stroke patient to a dedicated department. We shouldn't do that if we want to be in a hurry. We should go straight to the CT, as pointed out. We don't do that yet because some organizational issues. IVT-PA done in the CT, that's true, it should be done. We don't do it. And for drip and ship patients, we usually don't repeat the imaging. We do that often only in the patients where they are drastically better or worsen. Then we do repeat the images. And we try to progressively privilege mothership, because the patients lose a lot of time going to the different facility, 1 hour to 2 hours to come to us. And the major thing is pre-notification. We don't have the pre-notification. We don't do these things in parallel, as pointed out before, which is the major thing to save the time. So this was our situation before in the old building. So you see there's a neurology admission and triage. So the patient comes from the sanited vehicle and then comes there, and there he is evaluated by neurologist directly. And usually there is a dedicated nurse, neurologist, that recognize stroke amongst the multiple myriad of patients with the headaches, neurologic deficit, whatever. And she said to the doctor, well, there is a patient who could be stroke, and then he alerts others, and then he quickly sends the patient for the CT to this passerelle and down one floor, and then the CT is done, and the patient goes back to the neurology triage center, and then they call us when they see the pictures, and then again to this passerelle to the angio suite. So this takes time, as you can imagine. And to the 2021, we had this situation. Then a new building, 2022. We were very hype, and everything will be good. It is designed like a modern clinical centers that should have all in the one place. and it looked very promising. And we even have this new triage score for the emergency unit, and you see that for the patients that are intubated, there is no time, they're rushed into the CT or the diagnostic. Then this orange zone, which should be cardiovascular and cerebrovascular diseases, so you have 10 minutes to evaluate them and then quickly go to the CT, and in 10 minutes we should have the diagnostic. And you see the yellow one is 60 minutes, which are the other things, emergency things like ileus and so on, and the green is the patients that are not really endangered. And this is the situation on the floor, everything is on one place, so the patient arrives almost at the same place where there is admission. And this is the key factor, he goes to the yellow zone. So this is the yellow zone. We don't have an orange zone as I showed you, because there was not enough staff. So we have the yellow zone, and we have 60 minutes now for our patient, which are only mixed with the other patients, as I said, ileus, the other emergent patient. The other thing is neurologist is far away. So now that this patient, when he comes, then it's evaluated by the staff, and then call neurologist. If neurologist is there and is overwhelmed with the other headaches in the other patients, it could take 15-20 minutes for him to come and to evaluate our patient. Then afterwards is sent to CT, which is very close, goes back, and then they call us. And then again they call neurologist, and then they call us, and then when we come, we go straight to the cath lab. So everything is very near, but we have one new thing where the patient is one new bed, as you said, and then it took us to see how much it really changed the things, so better or for worse. And then you see when we look at the good outcome, we have a drop of the good outcome for the 10%, 5 to 10%. And this was a surprise for us, not surprise, but for the neurologists, the others, surprisingly. And we thought, why was our clinical outcome? There was a COVID at that time. What went wrong? Was it a COVID? And you see COVID? No, it's not COVID. It was better in the old facility than in the new facility. And then what went wrong? You see the door to neurology consultation, it went high up, so it's 15 minutes or more delayed. Then we gave some time for the door to CT, and then again to arterial puncture. Then we are late. Why late? Because all this movement of the patient takes time, and again door to localization is much higher, and what you get eventually is 10% lower for the good clinical outcome. So a new triage inserted, that gave us not a problem, it was not a solution for us. So this no 10 minutes orange room, but 60 minutes a yellow room really meant drop of the good clinical outcome for the 10% of our patients. So this is a real life situation. You saw the theoretical and everything. Now you see the real life, how it works when the things are not put in the right perspective. So what we need: pre-notification, triage before patient arrives, diagnostic from the ambulance. So they tell us there is a patient coming like this. Everything doing in parallel. Is also red color for the stroke, not the yellow, not the orange. They should go straight directly to the diagnostics, and bypassing in-hospital triage, as said before. Thank you.
Wow, I will comment first. I think this is exactly what is needed to have the times there, because the time, everyone may think, oh, it's going great. And actually, I bet if you ask people on the ground, even during a case, and it seems as if it's gone fast, but if you look at the times, it hasn't. And the main delay that I've seen is bringing a patient to a different bed, because all the transfer, especially if there are cables attached, takes time. Now, one of the advantages, if you knew when the patient arrives with a pre-notification, you could have the stroke team meet the patient at the door, and you use the paramedic staffing support to already slide the patient on. And the assessment, doing that assessment whilst the patient is moved on the table, you already see, you have a broad assessment, is the patient severely affected? And also, again, on the angio, it was with us, it was at first a big discussion because some team members wanted to intubate the patient in a separate room or on a... Yeah. So if you intubate the patient directly on the table, you save another 20 minutes because you can work in parallel. So rather than storing them somewhere else. And we had a similar problem, also didn't realize that we had our yellow room in front of the cath lab.
Yeah.
And
like
patients were just parked there, they were forgotten, well, not forgotten.
It seems that they're near, but no.
Exactly. Directly waiting in front of the door, pushing to come in. Yeah. So really congratulations on doing that exercise. And I think here a communication tool will make a huge difference.
I think two things that you pointed out. First of all, audit. We need audit for each step, and then to see what doesn't work. And this new bed inserted, it means more people involved and more chaotic situation.
Yes.
So that's the point.
In my mind, every time when you do the observation or audit of the things, anesthesiologist is on the top of the problems. But in my mind, because in my hospital, I often have problems with anesthesiologists because they are rare and sometimes it's not possible to receive anesthesiologist on time. And for this reason, in my series, I do the most of the cases without general anesthesia. I do with the local, or of course posterior circulation I do with general anesthesia. Yes. But the main problem is become from the anesthesiology team.
The other part I found very effective is having competition amongst teams for prizes for the fastest times. And what Professor Fassbender did, and he found a big difference, he did a randomized study where in the mobile stroke ambulance he installed a big clock where people were seeing that they're running against the clock. We see the same on our app. The time is running down when the patient was there, and you can also put target times. You can say, within 20 minutes, I want this patient to have had their angio. So there's some small things that can be done, but achieving any change after something is established, I congratulate you for what you've already achieved.
Yeah.
And
this updating of the staff that brought the patient, as you said, this is very important, I think, also for them to know that they save the patient. Patients are good. He has the family. Family is happy. So they
and just another thing that we noticed, because when I started in my first cardiac center that I was setting up, we were at the time part of a randomized three-arm study where we were holding thrombolysis to patients and going directly for thrombectomy. So the ethics committee had mandated arterial puncture within 30 minutes. And so what we did is we did simulated training with the whole team members competing against each other, but it only worked. The trick was changing each other's roles. So you had to think outside of the box. So the radiographer became the doctor and vice versa. And then said, well, why don't we do this? So this is another thing. So really congratulations on what you've done.
Thank you.
Thank you.